Welcome everybody. I would like to introduce Dr. Erin Buckley. Erin works at the Martineau Center as a research fellow. She has a PhD from University of Pennsylvania in physics. After her PhD, she worked as a postdoctoral research fellow at Boston Children's Hospital for 1 year, and then she went to Martineau. Right? So today she's going to be talking about NIRS. Welcome, Erin.
Thanks. So is this audience mostly MR people or all walks? Mixed. Okay. Good. Okay. So, yeah, thanks for the introduction. So today I hope to give you kind of an overview of optical spectroscopy for monitoring. I use it in babies, but it can be used in adults, older pediatric patients, and then not just in the brain. People use it for breast imaging, muscle imaging, all sorts of things. So I guess keep that in mind as you're listening. But so most of you are already familiar with diffuse optics, whether you know it or not. If you've ever taken a flashlight and shown it on your hand, what you notice is even though you're sending white light in, your hand glows red, so only the red light's getting through. All other wavelengths are absorbed. And then you also notice that your hand, you can't see distinct features, you can't see bones like an X-ray, but your hand glows. So this is because tissue is highly scattering, and it leads to a diffusive transport of light through the tissue. And if we look at the absorption spectrum of the two main chromophores, or two main things that absorb light and tissue in the brain, which are oxy and deoxyhemoglobin, which I realize I didn't label here, but it's in red and blue here, we see that absorption is really low in the near infrared, and that's why the red light is able to penetrate so deeply. And the goal of diffuse optics is to look at the optical properties of tissue and relate that back to physiological properties in the tissue, like oxygen saturation, blood volume, blood flow, oxygen metabolism, etc. So we use two main techniques: frequency domain NIRS and diffuse correlation spectroscopy to measure these parameters. And today I'll talk to you a little bit about just a background on the techniques, some work that we're doing towards commercialization of the device, and then I'll highlight some selected applications that we've been pushing in neonates. Right, so I'm interested in neonatal brain monitoring in both health and disease, and the unique thing about neonates is, as opposed to adults where there's so many different modalities that you can use to measure brain perfusion and tissue health, like MRI, SPECT, xenon CT, PET. In neonates, your monitoring modalities are really restricted because you don't want to expose them to radioactivity. You certainly don't want to do anything invasive, or transport can be difficult. And not only that, but when babies are sick, they can be very fragile. They're susceptible to hypoxic ischemia. They may have impaired autoregulation or vascular reactivity, so you really don't want to be manipulating them very much. So right now, the main techniques that are used to monitor the brain are EEG, which obviously looks at electrical activity, not hemodynamic activity. Some centers, Boston Children's being one, use commercial NIRS devices that measure trends in cerebral oxygen saturation, and I'll talk to you about the limitations of that a little bit further into my talk. People also use Doppler ultrasound to look at macrovasculature, but again, you're limited to looking at the brain on a large scale, and we really want to know what's going on the microvasculature level. And then there are, times where it elicits taking the baby to an MRI or CT scanner, but you really just get the snapshot in time, and as soon as they leave the scanner, we don't know what's going on. This is a baby that I measured at the Children's Hospital of Philadelphia, where I did a lot of my initial work. So you can see this baby had a congenital heart defect, his chest is still open, he's got tubes all over. You really don't want to be moving this baby to an MRI scanner if you can help it. So there's really this unfilled niche for non-invasive cerebral monitoring in babies. And diffuse optical spectroscopies have emerged over the past 10 to 20 years as a really robust way of monitoring the brain. Like I said, we use frequency domain NIRS to look at microvascular oxygenation and blood volume. And then we use diffuse correlation spectroscopy to look at blood flow. And when we combine the two, we can get an index of oxygen metabolism. These techniques are very portable. They're non-invasive, completely non-invasive. So this is a picture of us putting one of our handheld sensors on a preterm infant. We literally just hold the probe over the region of the brain that we want to measure. And they're safe. They don't use any ionizing radiation. And then from a technical viewpoint, what I like is that optics is especially indicated for neonates because they have a thinner skull and a smaller head diameter, and they have much less hair than adults. So it leads to deeper penetration into the brain of the light and better signal-to-noise ratio. So let me talk to you a little more about the technologies we use. So I mentioned we use frequency domain NIRS. It's used to monitor the static properties of tissue, oxygen saturation, blood volume. And we do this by sending in amplitude modulated light. So we modulate usually in the RF range around 110 megahertz. And after the light propagates through the tissue, when it's detected some distance R away, it's going to have some amplitude attenuation and phase shift. And we can use photon diffusion theory to relate this amplitude attenuation and phase shift as a function of distance from our source to the optical properties of the tissue, namely the absorption and scattering. And then once we have a quantitative measure of tissue absorption, we can derive the concentrations of the chromophores in the tissue, oxy and deoxyhemoglobin. From that, we can get total hemoglobin concentration, which is just the sum of the two. We can get tissue oxygen saturation, which is oxyhemoglobin over total. And we can get blood volume, which is proportional to total hemoglobin concentration. We can also use photon diffusion theory to model how light propagates through tissue, and what we find is that there's this banana-shaped probability distribution of light propagation through tissue. So the farther apart you put your source detector separation, the deeper the light's going to penetrate into the tissue. And the parameters that we measure, oxy and deoxyhemoglobin, are really this bulk average of this banana shape. So if we want to get the average of cortical tissue, then we need to put our source detector farther apart. We've assessed how reproducible these measurements are in neonates, and we see about a 10% reproducibility of hemoglobin and 5% in oxygen saturation, which is pretty good. Yeah. So we measured multiple times on the same baby, you know, who was. Oh, compared to like a commercial NIRS device, it's very good, and given the amount of local heterogeneity in the tissue, I think 5% is good.
It sounds like you said that you could measure another one 5% of the time.
Oh no! Yeah, like the standard deviation over the mean is 5%. Yeah. So I hope that clarifies things. So then moving on to diffuse correlation spectroscopy, which is a nice complementary technique to FDNIRS, which measures blood flow. So this technique was developed in the lab at University of Pennsylvania, where I did my PhD, and I spent most of my doctoral work kind of progressing the technique and starting to validate it in humans. And now what we do is, instead of sending in modulated light, we send in a coherent light source. And because the light's coherent, scattering off of moving red blood cells is going to lead to intensity fluctuations due to interference at the tissue surface. And so the faster the intensity fluctuates at the detector, the faster the particles are moving in the tissue. So we use this intensity autocorrelation function to quantify these intensity fluctuations, where the faster the intensity autocorrelation function decays, the faster the flow in the tissue. So this is sample data from a hypercapnia challenge that we did. So the red curve is the baseline room air condition, and the blue curve is during hypercapnia, where you expect to see increased cerebral blood flow. You can see the curve decays faster. So we use correlation diffusion theory to relate this correlation function to or to fit the correlation function to simple models and extract a blood flow index. And then this blood flow index depends on both the speed of the moving scatters and their concentration. And I call it an index because it doesn't have the traditional units of blood flow. It's got units of centimeters squared per second. But we found, and I'll show you in the next couple slides, that it does correlate very nicely with cerebral blood flow. Okay, so this is just a summary of some of the many validation studies that have now been done. And at this point, I could say with confidence that relative changes in cerebral blood flow measured over time with DCS correlate very nicely with relative changes measured by other cerebral blood flow modalities. And Turgadur recently wrote a paper in Neuroimage that's really thoroughly goes through all these validation studies. But I'll just highlight a few. These two in blue were done in piglets against fluorescent microspheres and against bolus tracking time domain near-infrared spectroscopy. And then these two in black were done in humans. The one in the bottom right is done in neonates, and in the middle is done in kids who are less than 5 years old. And in all of these studies, we saw a slope of about 1, or a ratio of 1 to 1 between our measured changes and other modalities. So we're pretty confident in what we're measuring there. As far as the absolute blood flow index, in neonates, this blood flow index is proportional to blood flow. So these are two studies, one done in human neonates and one done in neonatal pigs, looking at our blood flow index measured by DCS and blood flow measured by, in this case it was phase-encoded velocity mapping MRI in the sagittal sinus, and in this one it was time domain, bolus tracking time domain NIRS. And again, we see a nice correlation. Obviously, it's not as tightly coupled as we'd like in the humans, but that's to be expected because DCS is looking at microvasculature, and the CBF we measured was in the sagittal sinus and the macrovasculature. In older patients, the effects of extracerebral contributions are no longer negligible, and so we have not observed correlation between blood flow index and blood flow in these patients. But with improved modeling, I'm positive we can get there, and we're working on it as we speak. And then with DCS, we see a reproducibility of this blood flow index of about 13% of the neonates. And again, reproducibility meaning standard deviation over the mean of multiple measurements. So, like I said, when you combine FDNIRS measures of oxygen saturation with DCS measures of blood flow index, we can get an index of CMRO2, or cerebral metabolic rate of oxygen. So we use Fick's law, which says that CMRO2 is equal to oxygen delivery times oxygen extraction. For the extraction, we use our FDNIRS measure of SO2, which we know is a weighted average of arterial and venous. And people have done studies to show that it's about 75% venous and 25% arterial, so we can replace this venous oxygen saturation in our formula with our tissue oxygen saturation. We use our blood flow index for blood flow, and then we can use pulse oximetry or blood gases if the patient has them to get arterial oxygen saturation and oxygen content. And so finally, we arrive at this index of oxygen metabolism. Again, it's an index because it doesn't have the traditional units, but we do believe that changes in this index correlate to analogous changes in CMRO2 with other modalities. And I think it's important to keep in mind that 90% or over 90% of ATP production is produced by oxidative metabolism. So CMRO2 really gives us a more complete picture of energy, cellular energetics, and tissue health. So, and I'll go into that a little further later. This was a validation we did of the CMRO2 index. This was in 32 neonates with congenital heart disease, looking, again, using phase-encoded velocity mapping in the sagittal sinus, along with susceptometry MRI to get venous saturations. And again, we see a significant correlation between the two modalities, not the tightest slope, but we're measuring different regions, so we're pretty happy with these results. So at this point, I should probably step back and talk about commercial NIRS devices, which maybe you guys are familiar with. I know they use them here at Children's. They're most useful as a trend monitor of regional SO2. There's so many different options available. I know they use the Invo system here, and I think they use the Foresight as well. The companies never publish their exact algorithms, but what we know is that they use two source detector separations, one that probes shallow tissue and one that probes deep tissue, and then they somehow eliminate those shallow contributions from their signal, and they make assumptions about tissue scattering and path length through the tissue, and then they get this oxygen saturation. But because of all these assumptions they have to make, the SO2 comparisons across subjects aren't always very good and or meaningful, and certainly across cohorts, it's also challenging. So, and then furthermore, if we want to use them as a monitor of oxygen metabolism, they really fall short, and we can see why when we look at this equation for CMRO2. They're really only, SO2 is only part of the equation, and it's highly dependent on cerebral blood flow as well. I think this study done here by Ellen Grant and colleagues looking at the acute phase of neonatal brain injury really points out where commercial NIRS devices can fall short. So she looked at 14 brain injured and 19 healthy control babies. They were measured with frequency domain NIRS within the first 2 weeks of life. So the brain injuries they had encompassed metabolic, hypoxic ischemic, hypoglycemic, and focal ischemic insults. And so if we look at SO2 between the two groups, you know, maybe there's some slight elevation. It was not statistically significant, nor would it be considered clinically significant at all. But if we look at CMRO2, we see significant increases in the brain injured group, likely due to the, you know, increased oxygen consumption that can be accompanied by increased neuronal activity due to excitotoxicity. But if we had just been monitoring SO2, we would not have been able to detect that injury. So my goal is to take these, you know, novel optical techniques and bring them to the clinic with the goal of individualized bedside patient monitoring. And with these aims in mind, we've been working to commercialize a new FDNIRS DCS instrument. So this was done in collaboration with Canon USA. And the goal of this new instrument is really to streamline our measurements. This was a picture of our old instrument. It's nice, but it's not that nice. So this is our beautiful new instrument that's all nice and compact and really easy to wheel around, and it has a battery power, so we can long-lasting battery power, I should point out. So we can set things up and then wheel it to the bedside. And the goal of this instrument is really just to streamline our measurements. So we do this first by reducing data acquisition time. So the way we currently do our measurements is we do FDNIRS measurements at multiple locations on the head, and then we'll do DCS measurements at those same locations. We can't operate them at the same time because the laser from one interferes with the detectors of the other. So we've modified this system so that we can now take simultaneous data. So we've reduced our data acquisition time by half. We're working to improve the software control so that just one user can do the whole measurement instead of having somebody have to hold the probe and the other person operate the computer. And then we've also updated our patient interface. So I included all these slides, but I probably should have taken them out because they don't mean much to you. But basically, we use 8 wavelengths, which span the near infrared. So we get a really nice, complete picture of all the wavelengths, and we can get more accurate readings of oxy and deoxyhemoglobin for FDNIRS. For DCS, like I mentioned, now we're using a higher wavelength laser, so we can add filters to our FDNIRS system so that we can operate the two simultaneously now. And then this is probably most of our advances in our optical probe are pretty technical, but basically now our fibers are all in a line. so we're probing the same region with both FDNIRS and DCS instead of before, when we were making all the FDNIRS measurements first and then doing DCS, we were just kind of ballparking the same region. So that's certainly an improvement now. Our software control, the instrument's controlled via USB, and it has MATLAB GUI-based user controls. So right now we've just written software that acquires the raw data, but we're working towards guiding the user through the entire measurement process. And that's really going to help to improve data quality. If we have a bad measurement, we can then, retake the data on the spot instead of finding it out a couple days later when we're doing the post-analysis. And then, we've done initial tests on the instrument. This is my arm. Put the probe on my arm and just do a cuff occlusion, and we see nice expected response where SO2 decreases and flow decrease when you cuff the arm. We just got the IRB approved, I think pending laser safety approval, and then it's going to come here. So we're going to start making measurements here in select populations and comparing it to our current instruments here. So it's moving to the clinic. So now, speaking of applications and making measurements, I'll switch gears now and start talking about clinical applications of these techniques. So I spent most of my time when I was at the Children's Hospital of Philadelphia and Penn working with kids with congenital heart defects. So I'll start by highlighting some of the results there. And then I'll switch gears to talk about some of the results we've gotten here on healthy newborn babies and preterm infants. And then I'll talk a little bit about a new study we've been doing in an animal model of hypoxic ischemic encephalopathy. So we characterized baseline preoperative hemodynamic parameters for the first time in a cohort of 32 neonates with congenital heart defects. Most of these babies had either hypoplastic left heart syndrome or transposition of the great arteries. So here I'm showing the median and interquartile range of all the parameters we measured, and a mean value for healthy babies that I found from literature. What we see is that SO2 is substantially decreased in these patients by about 20 points. Oxygen extraction is increased, and then blood flow, blood volume, and oxygen metabolism are all depressed as well. I guess I should point out here that healthy babies, it's really hard to find measurements of healthy CBF and CMRO2. I mean, they just don't exist. So, you have some literature values, but that's one nice perk of optics is we can actually now start making these measurements in healthy babies, and we have been, and I'll show you that data shortly. What we notice is these parameters are actually much more similar to values that have been published for preterm infants, which makes a lot of sense from previous literature published on infants with congenital heart. Even though they're full term at the time of these measurements, it's been shown by MRI and other modalities, as well as our data, that they look more like preterm infants, and this is due to the fact that they grow up in this oxygen-deprived environment due to their heart defect. And then my colleague Jen Lynch, I don't have the data here, but she just built upon this work and looked at SO2 as a function of day of life. She found that in congenital heart kids, it decreases substantially, like 50% over the first couple days of life, and it's highly correlated with postoperative outcomes. So she looked at white matter injury on postoperative MRI and saw significant correlations. Lower SO2 was correlated with more injury post-op, so we're really excited about that data. We also looked at cerebrovascular reactivity in these neonates as well. So it's known that these babies with congenital heart defects have significant neurocognitive impairments later on in life, and given that impaired cerebrovascular reactivity has been linked with adverse outcome and death, we wanted to assess how these kids are doing. So we did a simple hypercapnia challenge where we did 30 minutes of baseline and 30 minutes of a fraction of inspired CO2 of about 3%. And we found that actually despite the fact that their preoperative baseline cerebral hemodynamics were substantially different from normal, their cerebrovascular reactivity was pretty normal. So this is a histogram of percent change in CBF per change in partial pressure of CO2. And you can see that their median value is right around the normal range for adults. I don't have normal cerebrovascular reactivity in babies, but and we also did not find any link between cerebrovascular activity and postoperative, pre or postoperative injury seen on MRI scans. In the process of this study, we also happened to capture a lot of our patients had mild acidosis, and so they were treated with sodium bicarbonate. And we were able to monitor what happens when you give sodium bicarb. So bicarb has been linked to intraventricular hemorrhage and adverse outcome in preterm infants. So we know it's doing something to the brain. And yeah, we were able to capture what it does. So 19 of our patients with hypoplastic left heart syndrome were given bicarb as a rapid injection to treat mild acidosis. And this is cerebral blood flow as a function of dose of bicarb at 1 minute post-injection. You can see there's a high correlation between the two parameters, which is likely due to the production of CO2 that's caused when bicarb reacts with acid in your blood. And this correlation goes away basically by 10 minutes after injection. But this was really interesting because these dose-dependent increases in CBF are an important consideration in vulnerable populations where the risk of a rapid fluctuation in cerebral blood flow does not outweigh the benefit of treating the acidosis. Okay, so now here at Children's and MGH, we've done a lot of work with healthy babies and with preterm infants. So this was some of the initial work where we looked at changes in cerebral oxygen saturation and oxygen metabolism over the first year of life. So this was 47 infants. They were measured, some of them were measured multiple times, anywhere from preterm to 12 months of age. And we saw substantial increases in CMR2, which agrees with PET literature that shows increased glucose consumption over the first year, or glucose uptake over the first year of life. And I'll point out again, SO2 seems to stay pretty constant with age. This suggests that, I mean, SO2 is constant, but CMR2 is changing. So this suggests that the oxygen delivery is able to match local consumption, and so SO2 can stay constant even though CMR2 is increasing. We also looked at regional and hemispheric differences in our babies. So we saw that CMR2 in the temporal and parietal regions were significantly higher than in the frontal region by about 20%. This is consistent, again, with PET results that show that the highest glucose uptake is in the primary motor and sensory cortex, and that the frontal cortex develops later on, like at 6 months. These babies that I'm showing here were all measured within the first 3 weeks of life. So we also saw CMR2 is higher in the right versus the left, and this is consistent with this theory of right hemisphere conservation, where people believe that the right hemisphere develops earlier and is less subject to change, whereas the left hemisphere is more plastic, which allows for development of language exposure and motor skills. And then in preterm infants, we've done a lot tracking preterm infants during the course of their hospital stay. So we measured 54 healthy preterm infants. By that I mean they didn't have any significant cerebral or pulmonary conditions. And if we look at SO2 versus post-maturational age, we didn't see any correlation. Here I'm stratifying my data by group. So orange is 25 to 28 weeks gestation, red is 28 to 32, purple is 32 to 35, and blue it's green, right? Yeah, green is 35 to 37 weeks. So we didn't see any correlation with post-maturational age. But if we look at SO2 versus age, we see substantial changes over the first 4 weeks to life. So SO2 drops about 20% over the first 4 weeks. And it plateaus around 60 to 65%. And we also find that it's highly correlated with hemoglobin concentration. And so that's why SO2 is elevated at birth, because you've got higher hematocrit as you go from that fetal to neonatal hemoglobin transition. We also looked at CBF and CMRO2 and saw increases in both parameters with post-maturational age and with age. I'm not showing age here, but we saw it with age as well. So given these drastic changes that we're seeing in healthy and preterm infants, and also given how different kids with congenital heart defects are from what we believe to be normal, we just started an investigation of healthy development over the first 96 hours of life. So we're interested in that really critical fetal to neonatal transition period. Because with infants with congenital heart, like I said, we see substantial drops in tissue oxygen saturation. With kids with hypoxic ischemic injury, you anticipate to see lots of hemodynamic fluctuations, but we don't really have a sense from the literature of what is normal. So we're hoping to ascertain that now. So this is the data that we see for SO2, blood volume, CBF, and CMRO2 over the first, I stratified it by the first 3 days of life for the frontal, temporal, and parietal cortices. And you can see even right after birth, we're already seeing that the temporal and parietal metabolism and flow are higher. And we're also seeing an increase in metabolism in the parietal cortex with age. Potentially this is due to increased sensory stimulation following birth. We don't know. This is only 8 subjects so far, so recruitment's ongoing. Okay, and then the final thing I wanted to talk about was hypoxic ischemic encephalopathy. There's about 2 to 3 cases per 1,000 live term births, and it's characterized by depressed level of consciousness, abnormalities in tone, seizures, respiratory depression, and apnea. And the outcomes are pretty bad. Approximately a third of the infants die. Only 20% of survivors survive with normal neurological function, and they have significant rates of impaired motor function, cerebral palsy, blindness, deafness, Bailey score less than 70. They don't do well. So the mechanisms underlying this brain injury are often the subject of neuroimaging, and it's something that we've been very interested in. So we know that hypoxic ischemia triggers a cascade of events that lead to neuronal death known as the excitotoxic cascade. And it involves the depletion of ATP followed by excessive neuronal stimulation and buildup of intracellular calcium and lactic acid, which leads to ultimately to cell death. And so the therapies aim to stop this excitotoxic cascade that lead to a secondary attack and subsequent cell death. And really right now, the only therapy with proven efficacy is hypothermia. So hypothermia improves survival without disability by about 40%, and it reduces death or severe neurological disability by about 30%. It's very standardized right now, so patients are given they're cooled within 6 hours of birth during what we believe is this window of opportunity to initiate therapy before that cascade has progressed too far. They're cooled for 72 hours, and then they're slowly rewarmed for 12 hours. So we know that hypoxic ischemia has many mechanisms of action, but it seems like the successful treatment will be associated with reduced energy metabolism and preservation of energy stores. And since we have this tool that can measure oxygen metabolism, we think it may be a really useful tool to study the disease. So our idea is, can we optimize the duration of cooling? First of all, can we identify patients who should be cooled or not cooled? You know, if you catch them at 6.5 hours, is it too late to start cooling, or can we catch them? How long should they be cooled, and how fast should they be rewarmed? These are all questions that are asked and really could probably are not answered in a population average sense, right? They probably are patient specific. So we're hoping that this technique can help to guide therapy. So to this end, my colleagues here with Ellen Grant have looked at 10 neonates with moderate to severe hypoxic ischemic encephalopathy treated with hypothermia, and they compared them to 17 healthy controls. So the patients with HIE are shown in color, and the normal controls are shown in black. And here I'm plotting CMR02, CBF, CBV, and SO2 versus age. So the gray shaded region, which you can barely see here, is where they're cooled. So you'll notice we didn't catch many infants before they're cooled. It's like a crazy time for the parents to spare her to consent at that time point. So if we then summarize this data, and this is just box plots of comparing during cooling versus post-cooling, and during cooling versus controls, we see that CMR02 kind of is the parameter that provides the most contrast. It's depressed during cooling as compared both to the post-cooling period and to controls. We also saw depressions in CBF, and surprisingly we saw CBV was elevated. Potentially, maybe if CBF is so severely depressed, CBV elevates to compensate. We don't know. And again, we saw very small elevations in SO2, just once again pointing out the need to monitor CMR02. So these results are super encouraging, and the recruitment for the study is ongoing, but it takes a long time to get these patients. So those 10 patients that I showed you took 3 years to acquire. And consent, like I mentioned, is very challenging, and parents are very stressed. So we're translating to a preclinical model. So in this way, we can do these measurements in a controlled environment and get fast results and manipulate the situation in order to, change things like cooling time and depth of cooling and stuff like that. And that's, I'll point out, that's one thing I like about diffuse optics is we can use it in humans and we can use it in animals just as easily. So we can make that translation and then go back to the clinic. So we're doing a collaboration with Susan Benucci's lab down in New York, looking at a model of rat hypoxic ischemic encephalopathy, which is really more of a stroke model actually, but people use it as the gold standard HIE model, animal model. So basically you ligate the carotid artery. The ligation alone doesn't really cause any damage to the rats, but if you combine it then with hypoxia, then you do see injury. So we're making periodic DCS measurements all along this time course. So we do carotid ligation, we return the pup to mom, then we do hypoxia. For the hypoxia, we do 7 minutes at 8% oxygen, and then they're allowed to recover either under hypothermia or normothermia, and then they're returned to mom. So for hypothermia, they have this fun little setup where the pups are put in cups that are then submerged in a water bath, and the temperature of the water bath is maintained to keep them cold. I should point out, because I think people get confused, they're not in the water. The cup is in the water. The pups aren't wet. So they stay in here for 4 hours, and we've been taking them out of the cup, making a quick measurement of blood flow and putting them back in, and we see that it doesn't affect their temperature. So we started off for this study just doing DCS. It was, just kind of a proof of principle study at first, and now we're starting to ramp it up. We just made a probe to incorporate FDNIRS as well and to start doing these measurements for real. But it takes about 5 seconds to acquire the data. We do measurements over the right and left hemispheres, and yeah, we make measurements there, and we use separations of 3 and 6 millimeters. So these pups at day 11, when we do the insult, they're skulls are really thin. So we're probing superficial cortical structures as well as deep cortical structures with these measurements. Again, we've assessed the repeatability of these parameters. We see about up to a 15% variability, and a lot of that is because these rats are awake when we make the measurements. You can see we're just kind of cupping them in our hands, so they do move. They're pretty helpless, but they do move while we're taking the measurements. Okay, so to date, we've taken preliminary data on 42 rats from 5 litters. They undergo hypothermia or hypoxic ischemia either on day 10 or 11. So we have 14 rats in the hypoxic ischemic group who recover under normothermia, so their average temperature was 37 degrees during recovery. And then we have 14 pups in the therapeutic hypothermia group who recover with an average temperature of about 31.5 degrees. So I also have data from controls and hypothermic controls, but I'm just going to highlight the hypoxic pups because the data gets really complicated, and the control data is actually quite variable because the longer you keep the pups away from mom, the more agitated they get and the more they move around, so it makes measurements a little difficult. Okay, so this is blood flow index for our 2 groups, the hypoxic ischemic and the therapeutic hypothermia, at the 10 time points we measured: before baseline, after ligation, before hypoxia, after hypoxia, and then 1, 2, 3, 4, 5, and 24 hours post-hypoxia. If we go through this data step by step, so I'm plotting here relative change in cerebral blood flow compared to baseline. So I'm using each pup as their own control, sort of. What we see is that following carotid ligation, you do see a reduction in blood flow in the injured hemisphere. This reduction is significant. There is a mild reduction in the left hemisphere, but it's not significant. And then immediately after hypoxia, we see basically flow is slightly elevated from pre-hypoxic levels in the injured hemisphere, but it's incredibly elevated in the healthy hemisphere. And if we look closer at that data, there's a significant relationship with time post HI. I mean, we can't measure everyone exactly at 0 minutes. So we see that right after hypoxic ischemia, there's a huge increase, probably due to there has been reports in the literature of reactive hyperemia right after hypoxic ischemia. So then following HI from 1 to 4 hours, we see a reduction in cerebral blood flow that's pronounced in the therapeutic hypothermia group, but is not significant in the hypoxic ischemic group. The differences are significant between the 2 groups. And then by 24 hours, by the next day, we see significant increases in both the injured and the healthy hemispheres in the hypoxic ischemic group, but not in the hypothermic group. So now we've been working to correlate these measures with outcomes. So unfortunately, I just got the outcome data, so I don't have any shocking results yet, but we did see differences in injury between the hypoxic group and the therapeutic hypothermia group. And given that we also saw significant differences in cerebral blood flow, I'm hoping we'll see correlations with outcome. So in the future, we're just now starting to quantify CMR02 by adding FDNIRS to our probe and looking at relationships with injury. And ultimately, we want to start hopefully we will see a relationship with injury, and then we can start guiding the therapy because we can get CMR2 in real time now. So with that, I want to thank you for your attention, thank all my wonderful collaborators, and open it up to questions if anyone has any.
I have a question.
Okay, maybe I should.
I know about I was wondering, so you showed this slide?
Yeah.
So, you know, I guess in terms of it's better. Is it?
You mean for the free, like for the
Yes.
DCS?
Yes.
For DCS, you have to use coherent light. Yeah. For FDNIRS, it doesn't matter. Coherent lasers are more expensive, so it's actually a nice attribute of FDNIRS that you don't have to use coherent light, because while you're interested in phase, it's the phase of this. We amplitude modulate the light, so it's that phase shift that we're interested in.
So this is just
Yeah, yeah. Well, they're both diffuse, right? The light diffuses regardless of whether it's coherent or not. Yeah. Right, right. Any other questions?
What's the smallest area of the brain you could monitor independently of where you've done modulate
Yeah, that's a good question. So, like, we've done finger tapping tests. So we put the probe over the motor cortex and then put it 1 centimeter away, and we no longer are sensitive to to the activation. So right, right, and there's actually a group out in St. Louis who's doing these fascinating experiments now with a head cap, and they're doing visual activation and seeing, you know, those beautiful patterns people get with MRI, where you know, you show a rotating screen and you can see it light up in the visual cortex. They're seeing the same thing with NIRS. So certainly our spatial resolution is not great. I would say it's on the order of a centimeter to maybe a half centimeter, but some types, yeah, for sure, and it's advantageous in that yeah, it can be done in we can do it at the bedside for preterm infants, you know. In fact, we've been doing it where we do gentle stimulation of the finger, and you don't have to worry about the noise of the MRI getting in the way, you know.
What about that? Cortical?
Yeah, it's all cortical. So in theory, you could probe the entire brain, but in reality, you have to be able to detect photons that have gone that deep. So the farther apart you put your source and detector, the deeper you're going, but the less light you're getting. So in practice, in babies, we can go maybe 4 centimeters, but so that means you're probing about 2 centimeters in depth.
The areas where there's no cortex.
Yeah. Right. Like the, yeah. Certainly, and even with neonates, even with skull, their skull is so much thinner, so it's a huge advantage, yeah.
Thank you very much.
Thank you.